Good morning, everyone. For those who don't know me, my name is Paul Wesson. I'm the Associate Director for Science for the Institute for Global Health Sciences, and it is my pleasure to welcome you all this morning to our June session of the IGHS Grand Rounds. And it is especially my pleasure to welcome our speaker today, who is one of my mentors, Dr. Monica Gandhi. Dr. Monica Gandhi is a professor of medicine and the Associate Division Chief of the Division of HIV, Infectious Diseases, and Global Medicine here at UCSF. She is also the director of the UCSF Center for AIDS Research and medical director of the HIV Clinic at San Francisco General Hospital. In her research, Dr. Gandhi has a special interest in HIV in women, including differences between women and men in exposure to antiretroviral medication and responses to therapy. She has been a key investigator in studying the rollout and uptake of pre-exposure prophylaxis for HIV. Dr. Gandhi earned her medical degree at Harvard Medical School. At UCSF, she completed an internal medicine residency and infectious diseases fellowship, as well as a postdoctoral fellowship at the Center for AIDS Prevention Studies. During her infectious diseases fellowship, she earned an MPH in epidemiology and biostatistics at the University of California, Berkeley. Dr. Gandhi has received many awards, including one from the National Institute of Health's Building Interdisciplinary Research Careers in Women's Health program and an Early Career Faculty Award from the Hellman Fellows program. We are grateful to host her today as she shares her insights on the future of HIV prevention. Please join me in welcoming Dr. Gandhi.
Okay, I'm happy to be here during these troubling times. So what we're going to talk about, what we're going to talk about is the need for PrEP with some recent modeling, just hot off the press from this morning about how many people need PrEP who are not getting it, HIV prevention. We'll talk about oral pre-exposure prophylaxis, the data on that, also the data on long-acting PrEP. And then we have to talk about how we're being hampered and what's going on under the current US administration globally and domestically to prevent HIV prevention from being fully realized. So this was even before the administration started. This is data from UNAIDS in 2024, which reflects what 2023 data was starting. And already, even before this, even before the election, the idea was that AIDS was at a crossroads. Because what UNAIDS updated us on is 40 million people are living with HIV worldwide. And there have been 1.3 million new infections in 2023, which is the exact same as it was 2 years previously, the same number of deaths, 640,000 deaths. There have been 88.4 million infections and 43.3 million people have died of AIDS. So we were nowhere even close to getting to where we wanted to be even before all of this. And we only have a 72% virologic suppression rate. Things were starting to happen in terms of more stigma, more anti-LGBTQ, decreased funding. Biden's administration had not actually reauthorized PEPFAR. Eric and I wrote a piece saying, please do, but it hadn't happened. Only a 1-year reauthorization was happening. So that's kind of setting the stage before, and now we're going to talk about HIV data on PrEP, and then we'll go back to what's happening now. What is PrEP actually? The idea is that you have a medication in your body when you get exposed to an infection so that that infection can't set up shop. So malaria prophylaxis is a good example. And in the context of HIV, the idea is to have an antiretroviral in the body. You get exposed to HIV and it can't take hold. And so we already knew about prevention of maternal child transmission with antiretroviral therapy. And the idea was that let's do the same thing for PrEP. Now, in terms of how many people need PrEP worldwide, by the way, UNAIDS told us in July that 10 million people need PrEP worldwide. And we were only at 2.5 million, again, before the inauguration. So we weren't even where we needed to be with the dissemination of pre-exposure prophylaxis worldwide. And then this is a paper that was just actually released on May 9th by authors from the CDC, that in this country, about 336,000 people were prescribed PrEP in 2021. But doing a very nice analysis, they calculated that 2.25 million people in the United States need to be on PrEP. So we are not also where we need to be with rollout of pre-exposure prophylaxis here in the United States. So what was the first oral PrEP agent studied, and what was the first study? That was the IPREC study. It was published in the New England Journal, and it was done led by investigators here like Bob Grant. And the idea here was to give half of the people placebo and half of the people oral TDF FTC. TDF is tenofovir disoproxil fumarate / emtricitabine. I'll now refer to it as TDF FTC, an oral pill, one pill once a day. It has a long half-life, 2 drugs in one, and it seemed like the right agent to choose for PrEP. And IPREC showed us that it worked. I mean, it was this data that helped launch the entire PrEP field, but it didn't work as maybe well as you wanted. It was 40% reduction in infection versus placebo, and that's compared to 96% reduction in macaques, where macaques, you could give them the pill every day, and it's hard to take a pill every day. It was even hard to take a pill every day in a clinical trial where you would get incentives to come in. So this is going to herald what's to come. And then there were many or several big pre-exposure prophylaxis trials that were done in men and women. And the 4 on the top had positive results. And the reason that's important is if you look at Partners PrEP, that was performed in heterosexual men and women, there was something very distinctive about that trial. The person who was negative would get, of course, the TDF FTC PrEP, but they knew their partner was positive. So if you know you're living and sexually active with someone who's living with HIV, you have pretty good motivation to take the PrEP. And in fact, that's what happened. And there were high rates of reduction of HIV incidence in Partners PrEP among both men and women. So it works equally as well for women. What threw people off a bit were these 2 trials, FemPrep and Voice, that started closing down all of a sudden, like arms kept closing down in 2010. And that's because actually TDF FTC PrEP did not work, did not show efficacy in young sexually active women in Africa in these 2 studies, South Africa. But importantly, it had to do with not feeling that they were at risk and taking the PrEP. It absolutely works equally as well for women as it does for men. And how did we know that they weren't taking the PrEP? Because actually, even though self-report was high in both Voice and FemPrep, over 90%, and even the return pill counts were high. So people were bringing in their pill counts and saying they had taken them. There were plasma collected in these studies to look at creatinine, and in the plasma levels in those in the active arm, only less than a third had tenofovir in their plasma, saying that they were taking the drug. So this both launched the field of pharmacologic adherence monitoring. This entire FemPrep Voice trial shut down, which is something that our laboratory here at UCSF focuses on. But beyond that, this really showed us that you want people to buy in to take the PrEP. And, in this case, the women, the participants in the trial were not convinced. This was before PrEP was approved, so they didn't even know if it was going to work. Lots of qualitative data thereafter has shown us that we have to work harder to help people take their PrEP every day. But it is really showing us that that's the problem with oral PrEP, is that you have to take it every day. You feel perfectly well and you have to take it every day. And that's going to herald what we're going to talk about with long acting. There was also couple of other oral options, but it depends if you're a man or a woman. So if you're a man, you get 2 other oral PrEP options. And one is intermittent PrEP. And this is the idea of taking 2 pills before the sexual exposure, and then 1 pill within 24 hours, and then another pill for 24 hours later. So 2-1-1, or intermittent PrEP strategy, or also called on-demand PrEP. And this was the IPERGAY study that showed us that on-demand PrEP works as equally as well as oral PrEP, because people know when they're going to have a risk, especially if you're very planny with sexual activity as opposed to more spontaneous. But if you're very planny, then this is a very nice 2 pills before, 1 pill after, 1 pill after. And even though this hasn't been endorsed by the CDC, everyone ignores that. And this is a very good option, 2-1-1. They ended up taking around 4 pills a week, which in even modeling with daily PrEP, it seems like 4 pills a week is the magic number. And that's also the magic number with women, as shown in a very nice JAMA study published by Jeannie Morazzo, who was just riffed from NIAID on April 1st. But she did a very nice study in JAMA in 2024 that I'd encourage you to look at. That cisgender women also just need 4 pills a week. So that's the magic number, 4 pills a week. Then there's also TAF-FTC. What is that? That is tenofovir alafenamide emtricitabine, so a cousin of TDF. Some problems with it and some benefits of it. So this was the Discover study, and this compared, again, only in men, so MSM and transgender women, specifically the strategy of daily oral TDF-FTC versus daily oral TAF-FTC. And TAF-FTC worked equally as well as TDF-FTC, so that's good. And it has theoretical benefits on bone health and renal health. On the other hand, there are more weight gain and probably more metabolic effects on TAF-FTC versus TDF-FTC. There was a mean increase in body weight of 1.1 kilogram in the TAF-FTC arm, whereas TDF-FTC seems to be associated with weight suppression. So whether you use TAF or TDF is really going to depend on your patient and what they want to do with their weight versus if they're at risk for renal or bone. And that's going to be just a decision you make. And very unfortunately, this strategy has not been approved yet for cisgender women, nor has the intermittent PrEP, though I think intermittent PrEP works and I think TAF-FTC works in women. So that's oral PrEP. And not just one other thing to say about oral pill taking is one of the most effective strategies we have to prevent HIV is getting everyone in the world on treatment, actually on treatment, taking treatment, and then you're going to halt the virus, which is why we say it's a combination of treatment and prevention that will get us to the end of HIV, and why this time is so particularly painful, because in 1981, when Ronald Reagan didn't talk about HIV for a few years, and that was really terrible. I was too young to know. I was in grade school, I think, but I will say that that sounded terrible for all of you. But this feels particularly more terrible because we have the tools. We have treatment and prevention. We didn't have treatment and prevention in 1981. We have all the tools. We could end this. We could absolutely make it happen. But those tools, the funding for those, dissemination of those strategies are being taken away. So that feels extra sharp right now. But it is true that treatment as prevention is an incredibly powerful strategy to end the HIV epidemic. And these are the 3 cohort studies, Opposite Attract, Panther, Partner, and Partner 2, that showed that is when these are serodiscordant couples. So one's living with HIV and one is living without HIV. And if the person who's living with HIV takes their oral ART and the viral load is less than 200 in their bloodstream, you can have as much sex as you want. You can have thousands and thousands of condomless sex acts, and there were 0, 0, 0 transmissions from the person living with HIV to their negative partners, even without PrEP. So that just means that treatment as prevention is very powerful. So we need treatment to prevent HIV and to end the HIV epidemic, not just for the health of the individual, but to stop the epidemic, and we need prevention. So as I've been alluding to, though, prevention, taking that oral pill every day can be hard. I actually am an adherence researcher, and the reason I'm an adherence researcher is very particular to me. I put my foot in some bone density screening as I was passing the Women's Health Center when I was really young, like 35. And it turns out I'm osteopenic and maybe even osteoporotic, and I can't take my calcium. I just don't take it. I don't take calcium or vitamin D. I don't know why. And it has to do with, it's hard to take pills every day when you feel well, and it's kind of for the benefit of the future, right? And so prevention, pre-exposure prophylaxis, it's been particularly hard to take that pill every day. And this was a study from Lancet HIV, which is a systematic review that looking across different countries and initiation of PrEP, that 41% of those on PrEP discontinued within 6 months. And even if you continued, suboptimal adherence was still described for 38% of individuals. And these were studies where the discontinuation rate was actually higher in East and South Africa, than other regions, and discontinuation rates were lower when adherence interventions were applied, which means all of our research is important on adherence interventions. And it was easier for the men or transgender women who could get non-daily dosing options. So PrEP is great, oral PrEP is great, but it can be hard to take that pill every day, and we've all seen it. And it's why I want to turn next to the data on long-acting pre-exposure prophylaxis. We knew early on when drug companies were starting to discuss long-acting injectable options that we wanted this. We wanted this for not highly adherent populations, which are the studies were actually performed in those populations, specifically for long-acting antiretroviral therapy with a combination of CAB and rilpivirine. But we wanted it for people who had a hard time taking those pills every day. And so even as they were being discussed, all of us were saying, we can't wait until these comes out for people who have adherence challenges, even if they weren't studied in those who have adherence challenges. And we're going to have to talk about access to when we talk in this next section of long-acting pre-exposure prophylaxis, but it does depend on the drug company stepping up. And in general, cabotegravir, the way it's worked with the rollout, there's been issues with it. Let's just say that. And we don't have the rollout that we want with long-acting cabotegravir. So what's the data, though, on long-acting cabotegravir for PrEP? There are two big studies, one essentially done in men and transgender women, and the other one done in cisgender women. So the one done in men who have sex with men and transgender women is called HBTN 083. And the study design was taking individuals at risk for HIV and randomizing to daily oral TDF-FTC versus cabotegravir administered every 8 weeks, so about 6 times a year. And there's been an open label extension phase of this study. And actually, the study was wildly successful, meaning not only was cabotegravir non-inferior to oral daily TDF-FTC, it was superior, even in the open label extension phase by 66%. It was even better. It was reduced HIV incidence even more because it can be hard to take that pill every day, and cabotegravir works well. The same findings occurred with HBTN 084, which was performed in cisgender women. And here it was even better, meaning it was even more superior than in the men trials, 88% reduction in infections above and beyond what was seen with the daily oral TDF-FTC. And the nice thing about HBTN 084 is that these were all young women, and they all by definition were having sex, and there were pregnancies, and very happily there was pregnancy data available that was presented in Munich at the International AIDS meeting this last summer. It seems like such a long time ago. And there were no differences in pregnancy and infant outcomes among the women who got pregnant and were on cabotegravir versus on daily oral TDF-FTC, which just means that it's safe in pregnancy and should be approved as such, and was going to be approved, was going to be in the guidelines. That data was going to be added to the HIV prevention guidelines to the CDC, but the HIV prevention division is threatened. So lenacapavir is the next long-acting agent that can be used for prevention. Lenacapavir must not just work at capsid assembly, even though it is called a capsid inhibitor, because to really prevent HIV, there must be places that it's working before you actually get to the assembly of the virus. And we would love to understand more from the drug company, all the places it's working. And I mean to keep on writing them and saying, tell me the data on nuclear assembly and transport. How much data do you have on that? But it must work at multiple places. And it's being used for treatment since 2022. The end of 2022, we got it for treatment in people with drug-resistant HIV. So we're somewhat familiar, at least centers like ours at Ward 86, we've been using lenacapavir for treatment. But what's the data in prevention? Well, there are two big studies. One is called Purpose 1 and one is called Purpose 2. And Purpose 1 was discussed at the International AIDS meeting in Munich. Linda Gilk-Becker gave that presentation, but then simultaneously with the presentation, the New England Journal paper came out. So you can look at that for the details. And this was really a study design that looked at all women. And there were over 2,000 women. It was a 2-to-1 design, over 2,000 women on lenacapavir. And then the other two arms were daily oral TDF FTC and also daily oral TAF FTC, because again, Discover was only done in men and we don't have data in women, and we needed this to be done a long time ago, but at least this was done in the context of this study. So now we're going to get data upcoming on daily oral TAF FTC in women. And if you look at the characteristics of the women, they were really young. The median age was 21 and it went down to 16. And so that just shows that that's good, because it is adolescent girls and young women who are so at risk for HIV. So they were young, they were sexually active, and there was a lot of STDs. And it was being performed in countries, South Africa and Uganda, where there actually was oral PrEP rollout. And despite that, you can see that only 6.7%, 6 to 7% had been on previous oral PrEP, which just shows how hard it is to either get PrEP or just take it or adhere to it. So really important to have a long-acting option for women. And then also a lot of, again, a lot of STDs, but also a lot of unprotected sex. So we're going to talk about pregnancy later. So the data, importantly, has to be given with the caveat that the New England Journal paper only gives us the median time of follow-up of 52 weeks. And this is a drug that's actually given every 26 weeks. So that means by definition, half of people got less than 52 weeks of follow-up, meaning they may have only gotten one dose. So we do need longer term data before we say, we never should use the word, this is 100% efficacy, right? That is, you always have to say followed up at a median follow-up time of 52 weeks. Let's see what happens at 104. Let's see what happens at 2 or 3 years. But at 52 weeks of follow-up, median time, there were no infections in those who are taking the lenacapavir. And there was some infections in the TDF FTC and TAF FTC group, and they didn't look great. But there was a reduction in HIV incidence in those two groups as well. And the reason they didn't look that great, and this was nice that drug level monitoring was done, is that there was adherence monitoring done, meaning looking at tenofovir diphosphate levels and dried blood spots in those who were on TDF and TAF. And there was a drop off in adherence that happened as you took the pill, which is, again, very common and very seen. And that was probably why those two arms didn't look great. And it will depend on if the FDA takes this adherence data and puts it together with the TAF FTC efficacy data, whether TAF FTC is approved for women for PrEP. We'll see. That would be kind of a unique thing for them to do, is look at adherence data and say it probably would have been higher efficacy with higher adherence. So in terms of injection site reactions, they happen. We use lenacapavir for treatment. We know they happen. We even had a bad batch a bit ago, and that hurt more. So they do happen, but they didn't lead to anyone getting out of the trial, because not only is this a clinical trial, but it's only every 6 months. So maybe you can take that pain every 6 months, but the nodules do happen, and that nodule kind of forms and then it goes away with time. And that's really the depot formulation under the skin. And most people don't care about nodules unless you're very, very six-packed. And some people in our clinic do care about nodules, but not that many. So there were a lot of pregnancies in the study because they were young and they were sexually active and they were women. And that was good for us to see that lenacapavir is safe in pregnancy. And this is pregnancy outcomes. So we'll later get infant outcomes. But look, the pregnancy outcomes, at least in terms of preterm birth or fetal demise, was equal in those who got lenacapavir versus oral. So it looks good in pregnancy. And I really don't think there should be any barrier. I think this data is enough for both CAB and lenacapavir in pregnancy. So the PURPOSE 2 trial then just did the same study design, but did it in men and non-binary individuals. And that actually showed that out of 2,180 men who got the lenacapavir injection every 26 weeks, there were 2 infections. So also very efficacious, again, at the median time of follow-up that is presented in the paper. So we'll look over time. We always are looking at extension phases of studies. Tenofovir, TDF, FTC looked great in Partners PrEP, but how it's taken in the real world did fall off over time. So, but this is the figure from the New England Journal paper. And so far, this data is looking good enough that it has been presented to the FDA, and supposedly June 19th is the day when they'll approve it. And I see no reason why they won't. And that will be both an exciting time and a bittersweet time given what's happening with funding, which we'll talk about next. I think long-acting can be really helpful for those with challenges to adherence. And we have shown that in our clinic and other clinics with long-acting treatment with a combination of cabotegravir and rilpivirine. And then this is a study that we did with long-acting cabotegravir led by Matt Spinelli in our clinic. Our urban safety net population basically means Ward 86 and a couple of other clinics in the San Francisco Health Network around this city. And 111 patients were started on cabotegravir as PrEP. And there was a lot of, because there is housing instability, active substance use, and half had been on oral PrEP before, and 1/3 switched over from oral PrEP, but 1/3 had not been on PrEP before. And at least 6 months retentions rate was 83%, and 83% of injections were on time. And that actually exceeds the initial rollout of PrEP in the city. That fell off pretty quickly in terms of adherence and retention. So I think it is a tool to help people stay on prevention, and it's going to be helpful to have. I think long-acting PrEP it could be very big for people who have a hard time taking that pill every day. This is a study that was presented at CROI 2025, and this is the PILLAR study. And the PILLAR study looked at HIV epidemic priority areas in the U.S. because in the first administration, Trump started in 1995 the End the HIV Epidemic initiative, likely because of Eric Goosby and Robert Redfield and others started this. I mean, this was a great initiative. It continues to be active, sort of, but it's diagnosing all HIV, responding to outbreaks, preventing HIV, and treating HIV. Those are the 4 pillars of how we organize HIV care in this country, or prevention. It was retained through the Biden administration. And in the End the HIV Epidemic Initiative, high incidence counties, of which San Francisco and Oakland are 2, were identified. And this was a phase 4 trial looking at integration of long-acting cabotegravir in 17 clinics in these high incidence counties. And 32% of people had not even gotten oral PrEP, even though they were at risk for HIV. And again, looking kind of like our data at Ward 86, 72% of participants completed all injections with cabotegravir, at least at month 12, and persistence was quite high. Month 6, 85%, month 12, 73%, and HIV acquisition, at least through the period of follow-up of the PILLAR study here, was 0. So no HIV acquisition, and there was acquisition of STIs, so there was ongoing risk. So it really is, I think, long-acting in these 2 studies, in our Ward 86 study and in these 201 participants in the PILLAR study, really look like it works well. And then one other comment to make about lenacapavir in terms of the young. There was an analysis at CROI 2025 that I'd shown you that Purpose 1 went down to 16. And so actually 16 and 17-year-olds, the PK of lenacapavir was compared in this study among the 16 and 17-year-olds in the study versus the 18 to 25-year-olds. And importantly, the 16 and 17-year-olds, even though this was done in South Africa and Uganda, were able to be enrolled without parental permission, which is very helpful to be able to control your own health at that point, at that time when you're sexually active. And the PK essentially looked the same. Like the PK looked good in 16, 17-year-olds than it did in older girls and women. And so I do think that this will be approved to 16-year-olds when the data is presented, as the data is being evaluated by the FDA over the next, has already been, and we only have 2 weeks till the date of approval. There are also a couple of pipeline agents for long-acting pre-exposure prophylaxis. One is the idea of taking that lenacapavir and changing it into a different formulation that won't be given subcutaneously, which I do think can be painful for people, and giving it intramuscularly, which seems to have very little pain for cabotegravir and rilpivirine, at least in our experience. So I think once an intramuscular formulation of len, whether it's actually given 6 months or a year, because I don't know if I want to let people go a whole year without doing some monitoring. But the way it was studied, just PK wise, was looking at a year of once yearly intramuscular, two forms of lenacapavir that are given intramuscularly. And then there is another product called MK8527, which is a whole different drug. It's called a nucleoside reverse translocation transcription inhibitor. And there's no NRTTIs out. There's one that may come called islatravir, and this is a cousin of islatravir, and it looks like this could be given once monthly, but we're still in the studies on that. In terms of that once yearly lenacapavir intramuscular form, this was shown at CROI, but also published simultaneously in the Lancet. And there are two forms of intramuscular lenacapavir. They're both novel. They're not the subcutaneous form. They're different. And there was intensive PK studies done. And it looked like actually once yearly len gave even higher concentrations than this red bars here, which is the subcutaneous formulation every 6 months. In fact, they may need to bring the dose down some because they were really high. And I really like the idea of every 6 months, just adjusting it for IM, because we do need to keep some track of people who are on prevention. No one wants everyone running around after a year. And so we'll have to see what the FDA will approve just based on PK data alone. And then we had to turn to access, because even before this new administration started, we're already very worried about that cabotegravir and ropivirine, which was studied as in something called the CARES trial in Uganda and South Africa. And it's not cabotegravir and ropivirine long-acting ART is not available worldwide. It just, the access is too low. And it has to do with, yes, both companies worked with the medicines patent pool, but one company not as well as the other. And we just don't have that access to long-acting treatment for the rest of the planet. And so what's going to happen with long-acting prevention will not just depend on Gilead, which makes long-acting lenacapavir, but will depend on the government coming back in, because I don't think any drug company can fully provide access to the entire planet, but PEPFAR could have. But to Gilead's credit, they are committing to providing HIV prevention rollout for low-income countries, and in fact, just re-ascertained that or recommitted to that just a couple of days ago by saying that essentially there's going to be generic companies, and they'll allow these generic companies in different regions to make lenacapavir at cost and give it out. I don't know if it'll be given out to everyone. Like, I think, again, the governments, not just ministries of health, but frankly, the US government needs to stop doing what they're doing, because nothing has ever happened just from one arm, a pharmaceutical company, for example, alone. We definitely need partnerships. So I'm not going to let this government off the hook. And that's what we're going to talk about next, which is the tsunami of what's been happening since the inauguration. Okay, let's start. Okay, let's just take a moment because it's going to be hard. Okay, let's start with PEPFAR. Dr. Eric Gooseby is someone I admire more than anyone on the planet, and Dr. Eric Gooseby led PEPFAR from 2009 to 2013. It is my privilege to call Dr. Gooseby my friend and a member of my family, and he made PEPFAR happen in a way that it hadn't even happened before then, because he would take Republican senators to sub-Saharan Africa and he'd show them things, and then he'd convince them by the dint of his personality. But PEPFAR was already really successful and amazing even before he came on, and then he made it better. And PEPFAR is threatened. So let's talk about PEPFAR first. So on January 20th, that was a very strange day, because not only was it the inauguration, but there were all these executive orders that came out that day. And they were nonsensical. Like, they were executive orders like there's no such thing as transgender individuals, there's only two biological sexes, and there's no such thing as diversity. And they were completely crazy and nonsensical. So seemed like maybe it wouldn't be that bad because they were just insane. And then PEPFAR happened, and that happened just 4 days later. So the inauguration was on a Monday, and January 24th was Friday. And what happened on January 24th is, let's take a step back and remember PEPFAR. So PEPFAR was started by President G.W. Bush in 2003. Dr. Gooseby was actually a part of it. And the idea was that you would give just a little bit of global health investment into a very important infection. And at first it was treatment and then it was prevention, and you could control the epidemic. And Dr. Gooseby later worked not just in PEPFAR, but worked in integrating, even after his stint as the Global AIDS Ambassador, he worked on how to integrate care and how to make sure that primary care got brought into HIV care. It was just much more than HIV. It's a movement, and it was really cost effective. There was a piece that was published in JAMA by Dr. Jay Bhattacharya in 2012. He's the new NIH director, that showed it was probably the singularly most important and cost effective global health program ever designed, and that was 2012. And it just got better from there. So it really works. It's an amazing program. And on January 24th, there was a work stop order put in place by the State Department on all PEPFAR activities. And that was maybe around 4 o'clock. And then all these people in the State Department, and maybe you were part of this, Eric, suddenly got all these models to Secretary Rubio's desk by midnight that night. They stopped people from eating dinner wherever they were in South Africa and said, go to your desk and put all these models about how many people are going to die if you stop PEPFAR. And they got those models to him over the weekend. And on January 28th, Rubio's department, he's the Secretary of State, put in a waiver. And the waiver was that care and treatment can continue under PEPFAR and prevention, but only for pregnant women. And the problem is that if you have, say a couple, say the couple happened to be named PEPFAR and USAID, and you cut out USAID, you cripple USAID, you hobble it, you just take away all but 15 employees, which is the minimum amount of USAID that's required by law. If you kill USAID, you've just hobbled PEPFAR so much that even though this waiver is in place, PEPFAR has been compromised, and they have been gutting USAID. So I always look at this model. This is called the PEPFAR Impact Tracker. This is the piece that Eric and I wrote on the bottom right. And the PEPFAR Impact Tracker tells us the excess deaths that have happened in this administration because of what they've been doing to PEPFAR. And as of this morning, 57,000 adult deaths and 6,079 infants have excess died of AIDS because of what has been happening to PEPFAR. And no, Elon Musk, people are dying, and they are absolutely dying. And the reason that they're dying is that so many people present for late stage AIDS. In the context of stigma, if you get diagnosed late and if you have low CD4 cell counts by the time you present, you need antiretroviral therapy right away, and you need treatment for opportunistic infections like fluconazole for cryptococcus. And if you are that vulnerable and then you hobble PEPFAR, then that's why people are dying. And this is a model from the Clinton Health Access Initiative. And this shows these different pillars. And you can see that prevention is severely disrupted. Testing is moderately disrupted. Advanced HIV, which is why people would pass, is severely disrupted. Treatment is moderately disrupted. And monitoring is very severely disrupted with these changes in PEPFAR that have occurred in the last 3 months. And so I wonder, even if Lindsey Graham yells at Rubio in Congress, what they're going to do with PEPFAR next. And the skinny budget, or the May 6 budget, which I guess is called the skinny budget, does actually have the word PEPFAR in it, which I look to Eric to ask, is that hopeful or not, especially if you've done this to USAID, which USAID started being gutted the first day of the administration. And at this point, along with withdrawing from the WHO, USAID is effectively dissolved. First, 5,200 contracts were cut out of 62 contracts, and now there's just 15 people sitting somewhere in the State Department who work for USAID, and they also moved USAID under the State Department, which means they can do whatever they want. And so my question, and I want to wait for our discussion and ask this, is it hopeful that PEPFAR is at least mentioned in the budget? And how much more would be needed to be given to PEPFAR to make up for what they did to USAID? And could Gates make that up, or will they make that up, or will something happen? And can we restore PEPFAR in some way? from the US, let alone what the ministries of health are trying to do, which they all were going to do anyway, but not, you shouldn't have to do it in a day, is take over all of HIV treatment and prevention. So I'm going to ask that of Dr. Gooseby in the question period. I think it's really sad that on April 1st, the WHO had to put out guidance on handling interruptions in antiretroviral treatment. We shouldn't be putting out guidance in 2025 of what you do when there are stockouts of antiretroviral treatment, because there shouldn't be stockouts of antiretroviral treatment. And we put out a paper in Lancet ID a month ago. This is with a fellow named Max McClure here, that this is just going to lead to dolutegravir resistance, INSTI resistance, because when the Soviet Union collapsed in 1991, you had TB therapy. They were doing a great job. I mean, communism and socialism is very good for health. So they were doing a great job in disseminating TB treatment. And then the Soviet Union collapsed and people had TB treatment at home and they were like, okay, I'm just going to take this every 3 to 4 days maybe. And of course, in any infection, needs combination treatment with HIV is one. If you take it every 3 to 4 days, you're going to get resistance to the components of that. And I think this is just going to drive up, what's happening is going to drive up INSTI resistance, which is first-line therapy worldwide. And there was already a model that was just published a couple of weeks ago that even before this model performed by Loosley et al. In Lancet Global Health, even before we talked about the PEPFAR cuts, their group modeled that if we keep viral load monitoring and resistance monitoring where it is, we're going to have a 42% rate of dolutegravir resistance by 2035 without amping up viral load monitoring and resistance monitoring. And how can you amp those up when you've just cut global HIV to this degree? So we have to watch and be very fearful, I think, of integrase inhibitor resistance unless we can turn this around. And on top of that all, even before the inauguration, the WHO, the US said they were going to pull out of the WHO, and they did. And on March 28th, they cut a fifth of their programs. So that's global health. And now let's turn to domestic for a minute. The first clue, okay, no one thought it was going to be this bad, I have to say. Like, I don't think anyone in this audience thought it was going to be this bad. But I think the first clue was the yellow box warning on top of the CDC guidelines. So the first week of the administration, there was a communications ban put on the CDC and the NIH and the FDA. And then in the midst of that communication ban, suddenly the HIV prevention guidelines came down and the STI prevention guidelines came down from the CDC. And those were really important guidelines. And everyone was trying to like take screenshots and figure out how to keep them up. And then on February 14th, by law, they had to go back up. But they went up with this terrible, like ridiculous box. And the box, I'll just read to you, says HHS is required to restore this website as of 11:59 on February 14th. But any information on this page promoting gender ideology is extremely inaccurate and disconnected from the immutable biological reality that there are two sexes, male and female. So the Trump administration rejects these guidelines. This page does not reflect biological reality, and therefore the administration and this department rejects it. So that's not how you put out guidelines from the premier public health agency on HIV prevention, to have this crazy, crazy box. And then what happened is HHS, I learned a lot more about HHS, which Dr. Gooseby already knew, but I learned a lot about HHS. And if you look at these 8 agencies of the HHS, I think only healthit.gov hasn't been affected. I don't see that they've bothered healthit. I'm very happy for healthit.gov, but everyone else, CMS is Medicare and Medicaid. HRSA is essentially administers Ryan White. CDC, NIH, FDA, and there have been major disruptions to all of these, and we'll talk about that. So the first thing that came out was February. This was the announcement. So there's lots of capital letters, and this was February 7th, but this was the Make America Healthy Again Commission, March 27th. And so this was the president's plan to make America healthy again. But the problem is the stated objectives of reducing chronic disease cannot be met if you cut out, for example, lots of staff, 3,500 staff from the FDA that would be monitoring food and health and food and safety of drugs. Or you can't, for example, think about environmental toxins if you cut out NIOSH, which helps us with environmental toxins. So the stated goals are not concomitant with what's happening. And usually people don't get to come into government who give 218 million to a campaign and just wreak havoc, but that's what happened. And so the thing about the HHS is it was actually established in 1953 as the Department of Health, Education, and Welfare. And then it got so big that education was separated out in 1980, and it's called now DHHS with those 8 agencies. And the reason that it has a budget, and it does have a budget, it's a budget that's, I think the largest the largest military budget that's ever been proposed was just proposed by this administration. And so that obviously the priorities are different, but this is this budget is high because it affects everything that we hold dear, which is our health and our insurance and public health and disease control and scientific research and innovation and food and drug safety and supporting family and communities and healthcare coverage. So that's why it has a budget. I mean, I'm not going to use the word large budget. It has the appropriate budget for these incredibly important aspects, because for any of you who is human, which would be all of us, we face morbidity and mortality. So what happened? 82,000 employees are now 62,000 employees from HHS, and FDA got cut by 3,500 employees, CDC by 2,400 employees, NIH by 1,200, and CMS, which is Medicare and Medicaid, by 200. And 20 divisions were consolidated or proposed to, and 10 regional offices are going to go to 5. And all of these other proposed changes are happening, but there's a possibility that we can turn some of this around. And that's how I want to talk about what specifically is happening at 2 of those agencies, which is the NIH and the CDC. So let's talk about the NIH first. It was okay between January 20th and February 7th. It was 2.5 weeks where it was like, well, no one's going to touch the premier biomedical research agency in the world. That basically there was this JAMA analysis that was published a couple of months ago that showed that 361 out of 365 drugs approved from 2010 to 2019 in this country were solely the effects of NIH-funded research. So any life-saving medical therapies are coming out of this organization. So why would anyone touch this? But it did get touched. And on February 7th was the first date that we knew things were going to be hard. And that was put out from the NIH account, like on their Twitter page, I guess, saying that the indirect rate as of February 10th would be 15%, which is, of course, the indirect rate can be up to 64% rate or even 69% at some places. It depends. It gets negotiated in each university. So over the weekend, 22 attorney generals, bizarrely only from Democrat states, when this is going to absolutely affect red states equally, put in a lawsuit, and there was a preliminary injunction filed, and that happened twice, and then a final injunction was filed. But the only reason there's a final injunction is because the Trump administration pushed them for final injunction, because they are still pushing this. They are still appealing this. And there is some concern that Congress, if they're going to fight for any hill, they may not fight for this. So we'll see what happens with the indirect rate. There also was an April 16th leak of what was called the passback budget on April 16th. This is in the Washington Post. And there was a bizarre amount of detail about the NIH in that budget, meaning that the idea was to collapse institutes so that all the institutes would be collapsed, and except for NCI and NIAID, that would actually stay intact. This budget says to cut out nursing research, to cut out complementary and integrative health, which is interesting because Maha, there's a lot of aspects in there about integrative and complementary health. Cut out Fogarty, cut out the National Institute of Minority Health and Health Disparities. And then this collapse of all these institutes into 5. And I just want to point out the particularly egregious concept of putting children's health under something called the National Institute of Disability-Related Research, because children are just little, but they're not disabled. So that is proposed, really, really details in this that I would have been very surprised from a presidential budget. And obviously they were in the weeds with this. And some of this will be debated. Well, this will be debated until September 30th. And then that was February, and then March, the termination started. And the terminations were brutal. They were ideologically driven. Maybe 1,700 are analyzed in a paper I'm going to tell you about on May 8th. And they seem to be particularly around DEI and gender minority, but there's some that have been terminated for the word hesitancy, and some we can't make head or tail because they didn't ban gay people, but it seems like there's some sexual minority ones banned, not as much though as gender. And mRNA, and China was banned, but they haven't been cut, and climate change is supposed to be banned, but they haven't been cut. So there's a not totally rhyme and reason, but DEI and gender is enough to say that that really affects the field of HIV. And there was a analysis done in JAMA on May 8th of the terminations at the NIH. And between February 28th and April 6th of 694 grants, there were 1.8 billion in terminated grants by that time. Oh, also money wasn't going out and continues to not go out as briskly in the form of what are called notice of awards from the NIH. But at least at that point, NIMH and then NIHMD, which is minority research, and that was most affected. But the actual dollar amounts most was cut from NIAID grants. And 57.6% were R01s mainly, but actually 20% were of poor early stage investigators who are trying to make their way in research. And UCSF was among the top because we get so much publicly funded research, but the targeted universities were also really up there. Harvard hadn't yet been targeted by the time the analysis, but they sure have been targeted now. And Columbia was very high. And they just were terminated. They were brutal, and they said nonsensical things in their termination letters, like there's no such thing as gender and diversity, and they were just nonsensical, and people have appealed, and there haven't been many that have been overturned yet. And the New York Times did an analysis on May 4th that about half really slash LGBTQ research, which by definition is our field. So if you feel particularly hurt and miserable as an HIV researcher, you have every right to, because that's what's been happening to your field. It's actually completely illegal to terminate clinical trials. I mean, unless a DSMB meets and says drug A is not safe compared to placebo, or it's not working, it's completely illegal. It violates the Nuremberg Code, Declaration of Helsinki, Belmont Report, but nonetheless. And beyond the terminated grants, also, money hasn't been going out briskly like it used to, and that has to do with DOGE being embedded and keep on watching grants, and they may have a word in there. And one time they had the word "they" in there, and that got flagged. I mean, I think it was referring to samples, samples were collected and they were put in the fridge. So that's called false positives, and there are false positives grants that are not going out. Study section and councils were canceled, but they seem to be on track. And then we have South Africa-based research, which I can't really tell yet. It's supposed to have been unblocked, but then it didn't matter because something happened with foreign subawards on May 1st, which we'll talk about next. And so I can't tell if it's particularly blocked or is just everything blocked. And we have to go back to the South Africa issue after this. After we get the foreign subawards issue straightened out, we have to go back and advocate for South Africa, which of course contains the highest, carries the highest HIV burden and also very high TB burden. This is a map that shows a graph that shows the amount of money going out from the NIH compared to previous administrations. So that top one is Biden 2021. The second line is Trump 2017. The third is Obama 2013. And the fourth is Trump first 100 days of the administration 2025. So that look is not great when you're going into a budget process. Let's forget a minute about rescission. And I know I'm not saying that word right, what they're trying to do. But beyond that, like you go and ask at a bank for money and you have a large amount of money in your bank account for a loan, that doesn't look good. It's not good to have a big surplus at the NIH going into budgets in July through September. So this needs to change. The NIH director, the new one, started on April 1st and named priorities that were confusing to me because population health sounds good, but HIV is a chronic disease. Reproducibility and rigor, it feels hard to say that we will be reproducibility when this is a time of austerity. I mean, they have a big surplus, but if you're not putting out grants, how can you reproduce? Innovation sounds hard when grants aren't going out. And safety and transparency sounds good, and academic freedom sounds good. But if you block grants to universities with DEI programs or who have enacted boycotts against Israel during this ongoing, very difficult, what's been happening in Israel, then that doesn't really sound like academic freedom because students are protesting what they feel is right. So on April 1st, there were mass layoffs, and a lot of them affected people who worked in HIV, essentially. So Jeannie Marazzo, the director of the NIAID, Emily Erberding, that would be more like infectious disease COVID, then Cliff Lane, deputy director of clinical research at NIAID, and then our beloved minority and health disparities. I should say Eliseo there was laid off. And then Christine Grady, chair of the Department of Bioethics, she's Fauci's wife. And so all these people were laid off. Those are high level, but then at the same time, all these rifts occurred at the different agencies. And again, 1,200 cut from the NIH. And that was also the day we'll talk about the CDC next. And then on May 1st, there was this notice that came out from the NIH that said foreign subawards are going to be changed to a different structure by September 30th. But instead of kind of having that gradual, how policy changes usually happen, it was all of a sudden, and no grants that had foreign components would go out. And that has had a real effect. It's May 1st, and now it's June 4th. And like clinical trials have been stopped. So this was a piece from Science. There's a piece in Nature and Science just on Friday that I'd encourage you to read about the impact of these on clinical trials in international settings and had a lot of effect for us as investigators here at the Institute of Global Health Sciences. Also on April 1st, there was this question of what's going to be cut at the CDC. And that day, Jonathan Mermin got cut. Well, he got sent to the Indian Health Service. So does Jeannie Marazzo, and great, amazing, led the HIV prevention division for so long. And all of this kind of piece of paper came out, and I'm sorry you can't see this, but all these divisions at the CDC are proposed to be cut on April 1st. And one would be important for us, of course, is HIV prevention, also global health research, also STDs, and then like lead poisoning and violence prevention and just random, so many things that seem associated with chronic disease prevention. So again, not concomitant with the stated goals of Make America Healthy Again. Actually, a judge said you couldn't do this. They said this on May 21st. They said you can't just rearrange government, but these individuals have not been reinstated. And then I told you about the April 16th kind of passback budget, which really does propose to cut out and the HIV epidemic initiative funding, which would be really hard because it's working really well. It's a great initiative. It's awesome. It like really works. We're really working on HIV prevention and treatment in the country of the United States. So dismantling HIV prevention will definitely cost a lot more than it saves. This is a nice article from STAT about that. And then if you're cutting out CDC programs, then you're affecting the South. And 52% of new infections of HIV being in the South and red states, that doesn't make sense if this is particular to blue states or anything, because it's really going to hurt the South, and it's hurting the South already because of the CDC cuts. So the release of the budget, I think the things I'm most worried about, Ryan White Care A and B are not being cut, which is great, but Ryan White F is, and that's dental and housing care for there's also dental and housing care for our people living with HIV. I'm thinking about the impact at Ward 86. And then I'll also just cutting the CDC's Global Health Center is very difficult for those of you at IGHS who do global health. And so none of these have been actualized, right? This is what's been proposed, and hopefully we all can do advocacy and prevent this from happening. And then the last final I think thing I want to mention is it'd be really, really hard for our population at Ward 86 if Medicaid was cut. And Medicaid, the House has passed the big ugly bill of 700 billion being cut from Medicaid, but the Senate hasn't. So we have some hope that this won't happen, though I don't know. And it would be really important for Medicaid to be continued. Again, it was very much helpful for red states, and maybe Bill Gates' money will help, but I don't think he's committing it to Medicaid. And we'll see how that money that he's committed from 2045 of 200 billion will help us here in global health. But I will end with I thought I had it. Well, I will end with an email that my patient sent me on April 9th. And this is before Medicaid was cut or proposed to be cut. But she said, well, what will happen to me? Will we just all pass? She just asked me that question like that, frankly. And I couldn't answer her. And I hope that doesn't happen. And this is where we are in the world. And sorry to end on that terrible note. Okay, I'll take your question. Eric, what's going to happen?
Comprehensive, really detailed, empathetic presentation of the topography that we're in front of now, which is evolving. And I think you really conveyed it nicely, as tragic as it is. The lack of thought in how it's been rolled out is infuriating to all of us, to see things unravel for no specific reason, with no specific outcome identified, but that because of the cruelty of these decisions, it's allowed to roll downhill, really unmanaged. And I've never been in a situation where a government has been more irresponsible, unwilling to engage in a planning discussion or a kind of strategic discussion, but let alone not willing to engage on where we are now, what we're doing now, and what changes are we proposing. But they have not dialogued in and amongst themselves in terms of the Trump administration, but they have had zero contact with any Democratic force outside. Anything that's associated with a Democratic construct historically has been completely out of the loop. People that kind of played both sides, like Mark Dybul was credible to the Republicans, those types of people have been kept out as well, and not given a kind of preview of what the thinking is. So it comes out in stuttered, kind of coded messages that are not enough information to rationally conclude anything. And it's deliberate. The best map is truly going back to that 2025 display of the comprehensive approach they were going to take. They really did do that. They did it in spite of the fact that the publication was published and there was a preview of what was going to happen. And I have to say, most of us looking at this happen are not coming from a frame of mind that knows how to position against this kind of an attack, and didn't perceive it as an attack initially even. And even after it was clear it was an attack, it took the group of people that we're talking about, their brains don't go to attack mode in a defensive stance, And I'm not sure it would have been better, but that is what's missing. We didn't have it in a congressional response. We didn't have any backstop in Congress, and we had no backstop in the executive branch. So the alternate border putting up guidelines was not present, and we were working under some kind of false assumption that it was going to engage. And the truth of the matter is that everyone was stunned with the kind of force of the hose, the water hose, trying to drink from a fire hose moment, with volume and with multiple areas of engagement. So it diffused any attempt to, mount a response against. I have to say that the Democratic Party's ability to understand and respond has been less than optimal, to say the least. Very disappointing, to be honest, and tragic when you really think about why this is the way it occurred. But nevertheless, is indeed a hole that we're in. I think that the slow return now. There's 15 people that the State Department with USAID has cherry picked, a group of people to look at program, look at country, and look at what should continue. And they're looking at probably, a half of the PEPFAR budget is still in play to be returned to program. So there will be good news that comes out of this, but there will be bad news for sure. Right now, we know it's not enough to go everywhere. Prevention is being minimized as a target. The idea of treatment as prevention and the utility of that is the drumbeat that the kind of PEPFAR discussion is depending on to not go away. Not to minimize the need for prevention in the ultimate containment strategy, never not saying that. But the truth of it is, if you were going to go for more people not getting infected and not progressing in disease themselves, I'd just get everybody on treatment and pull out all stops to do that. But I think the lenacapavir cherry pick is so attractive, it's hard to not just want to grab that. The deal Gilead made with WHO, FDA, UNAIDS were all involved, but Gilead really made the agreement with PEPFAR, and John McKingasong was at the center of that, did cut the deal for really a prevention utilization coming in before a treatment utilization for the long acting. And that would go to people with poor adherence compliance patterns already established, people with, instability and chaos in their homes, people at Ward 86, no homes, and substance abuse churning are the, domestic picture. But internationally, it's adherence for a lot of other reasons, poor adherence for other reasons. But it's the answer for that too. I mean, people really do see this as a real intervention that will bring that flood to cover more people. I'm thrilled at 75% undetectable. We were looking at none for decades, and that is an accomplishment by itself. But I'm kind of meandering around. But I do think the convening of the 15 is now where our money is. We will start to hear specifics about countries and programs, and the ability to dialogue with that will increase. The last thing I'd say is about the Senate. If they go with the House bill, I will be surprised. But my concern is that the opposition and senators' opposition to voting for it really is focused on its too large a deficit and not the specifics of the Medicare $700 billion cut that is hitting, going to hit a Medicare pot. Does not seem to bother them that much. You'll hear things about kids and nutrition and breakfasts and stuff. I'm worried that the roots of really that line drawing, normally I could tell you the Senate would never pass. And the history of House Senate is House does something stupid, the Senate doesn't approve it. And that's been the history of the Congress. And for all the AIDS issues, for every AIDS issue, going back to the 80s, it's always been that. House takes it away, Senate puts it back in or reverses it. I still think that's what we should expect, but I'm not as secure because of the way they're making their arguments. But Lindsey Graham is blowing my mind with how he is, trotting down the hill with the whole Ukraine-Russia fight, bringing him in a very funny way to this issue. He has Rubio's ear. We all had Rubio's ear. Rubio talked and was very PEPFAR sophisticated with a close monitoring of progress going back from, he entered around 2011 or something like that as senator. He was interested from day one in it, got 4 briefings a year from every PEPFAR director because his advocacy was strong and worked with our friend, Lindsey Graham was the kind of duo that would go together at it and pretty successfully manage it. Rubio was an advocate of PEPFAR in a strong way, understood it in a specific way, and has abandoned us in a terrible way because of all that. So I look at him as someone who has transgressed in a way that others don't, because I know he knows better. I know he deeply knows better. So it's a different act. But so I don't know if that sounded, I'm a little optimistic that, this week, next week, we will know more what we are in front of specifically and the lobbying will have to intensify. And we didn't talk about Columbia and Harvard. I would just say that this last weekend was with WAFA, and I mean, the last couple of days, and at Columbia, she says their faculty is ripped apart, that half their faculty thinks this is the dumbest thing that could have ever happened in our chain. And the other half are afraid they're going to get all their grants taken away, and it's immobilized them. So they are in a state that I hadn't appreciated in terms of really how ugly it is there. And we here dodged that bullet. Berkeley seems to have dodged that bullet too, but that's all festering and in my mind, not clear how it's going to play out.
Okay, well, that was helpful. That was, I think the optimism that I'm taking from what you said is that for the wrong reasons, the Senate may reject this bill. And that's the 700 billion Medicaid cuts. And then I also think that the Appropriations Committee, it is a small, like what's happening with the NIH and the CDC would go to the Appropriations Committee, and maybe that will be okay.
That will be okay.
Yeah, okay. I think we have to all pay a lot of attention in the next couple of months.
I think Scott will support you.
No, I am not, no one is, I mean, that's the other aspect of what Eric Gooseby said, like there's this randomness to if you know someone and maybe you can get in front of them. And so like any connections that anyone has to like through a personal, there seems to be someone who knows RFK Jr. that I know, and there seems to be someone who knows Jay Bhattacharya, and since we know Cassidy's office, like just do what you can to advocate with any random stray ear, try to get it into their ear, what you're trying to say.
When somebody who's in the PI level of engagement talks to them, they don't ignore it. They don't often react to it, but they don't ignore it. And it's a voice that is not in their face. The actual, recipients of these grants and people who run these, implement these programs, but also the research aspects of it. They need to hear that this is messing with your ability to do what you've been trained to do. And is that your intent? Call them on that. But that personal interaction is often what we're on at this point with it. And they've blocked all the traditional conduits to interact with the administration. So the normal, National Academy of Medicines have the same frustration with it. They convene useless things to try to just be part of the voice, but it's been a waste of their effort. They are completely not in a dialogue. Groups that you would think are definitely in dialogue. So it's a funny time. But I do think Monica's case, characterized.
Anyone who knows,
Yeah,
use that there and probably block you in front of
Hi, Eric. I met you in Thailand about maybe 8 years ago. No, probably like 10 years ago when you were at the Hypnotic. Yeah. Oh, my name's Suresh Rangarajan. I just joined UCSF this past month. It's great to be here, and I'm looking forward to being part of IGHS as well as an affiliate. I have experience. I worked in Asia for about 8 years, Bangkok, Thailand, and Vietnam. I ran a treatment program for FHI 360. We had a lot of patients on treatment, over like 13,000 patients on treatment in Vietnam. It was a subcontract through USAID. And I really pushed during my time there on HIV treatment as prevention. That was when like the 052 study came out, and there's lots of studies, and I did studies in Vietnam on that. And it was successful, and we were able to nail the cascade down in that country and transition it to, really got lucky from health insurance to supply the drugs. So, for the non-politicians in this room, I think a lot of us would be qualified as nerds or, kind of technical. When we talk about this and write things, something I heard that I teased out is that there's some care and treatment provisions may be preserved. So is the dialogue for a holding pattern, when you're in a tough situation, think there's any sort of benefit, in changing the dialogue from prevention, just say we need to get people on treatment and changing the language to treatment. And we know treatment is prevention, but maybe by changing the language to like, we just need to focus on treatment and as our kind of like a holding place.
That's really what we're fencing back and forth on the prevention treatment. Tension has always been there since the beginning of HIV. And there are constituency groups that advocate for either, not both. Then it became both for a while. Then it goes back to either, and now that we're in a money crunch, it's going to go back to people are going to go to their corners, is what it looks like is occurring. That's tragic. It truly is. But the utility of having a treatment program as your base for your research is how we've done it. I mean, to not have that clinical base precludes, preempts, and stops research from occurring. That's the population that we need to study, and we need to capture and retain them in a treatment relationship so we have that ability to learn other things from that same population that benefits them as well. And it's a win-win for everybody. That's how we've done it. And for that to be eroded is the anger that, Monica was conveying. That is really the tragedy of this thing. The model was working. Shit. Sorry, second row.
Thank you.
Thank you, Yvonne.
Thank you so much, Monica, for that presentation. No matter how sobering or, but also points for optimism. Really appreciate you coming here and sharing. Sorry. Oh, sorry. I really appreciate you coming here and sharing your knowledge and experience with us. So once again, can we all give her a great big round of applause, and thank you all for joining.